Welcome to the Health Leader Forge, where today's health leaders help to forge the leaders of tomorrow. I'm your host, Mark Bonica, of the University of New Hampshire's Department of Health Management and Policy and the Northern New England Association of Healthcare Executives. Our website is healthleaderforge.org, where you can find information about subscribing to the podcast, links and information related to the episode, as well as our complete archives. Today's guest is Bridget Stewart, the Vice President for Physician Services at the Elliot Health System in Manchester, New Hampshire. Bridget's career spans a wide variety of hospitals and clinical activities. She has worked at several famous Boston hospitals, such as Brigham and Women's, Boston Children's, and most recently before coming to the Elliot as the Vice President for Operations at the Joslin Diabetes Clinic. In addition to earning her bachelor's degree from Health Management and Policy here at the University of New Hampshire, she holds an MBA and a Doctor of Law and Policy. In this podcast, she talks about her career journey and some of the differences between the organizations she has worked for, and concludes with advice to early careerists. This full-length podcast is approximately 84 minutes in length, an abridged version of the podcast is available that only focuses on her roles at Joslin and the Elliot. Welcome to the Forge, Bridget.
Thank you. It's a pleasure to be here.
So I'm excited because you are the third Health Management and Policy alumnus in a row to be on the Forge, and you're the third senior woman leader, which I think is really exciting as well. So as I said, you graduated from the University of New Hampshire in 1996 with a degree in Health Management and Policy, which is my department. How did you choose UNH, and how did you come to be a Health Management and Policy major? Did you come in as a major?
It's a great question. So yes, I happened to work at Anna Jake's Hospital in Newburyport, and following a legacy of my grandmother, who was the head pharmacist there, and my mother, who worked there for probably about 20 years, I started as a transport tech and knew that healthcare was a place that I wanted to be. And as a transport tech, I was able to really kind of get around the hospital and see a lot about the different areas, and was really focused on business. And I think at 15, I scheduled some time with the president there. His name was Alan DeRozier. And I said, how do I get your position, type of thing.
At 15?
At 15.
Oh, wow.
So I had just started, I think I had just gotten a work permit, and I was in transport, and I was able to, kind of get on his calendar. I think they thought I was probably crazy, which at 15 you have a lot, I was bold. So I was able to get, a meeting with him, and I don't know where he is today, but it was probably that meeting that really kind of gave me the, oomph to really understand that the business aspect of healthcare was big, and it was important, and it, played a large role in, delivering healthcare as we did then and as we do today. So I would say that, that was when I knew healthcare was where I wanted to be, and then that business side. I went to a school in Byfield, Mass. It was called Triad, and the guidance counselor was aware of a program that we have regionally in the Northeast. They used to call it the Apple program. I think it's something else now. Okay. But it allowed me in Massachusetts to get into a UNH school for, I think, in-state plus half or something like that. And it was great. It gave me the opportunity to learn about UNH, about the program. I met with, I think it was Richard Lewis was the dean back then, and just immediately fell in love with the program and came in as a freshman in the program.
Okay, so that I think that program is still available. I think it's called the New England Exchange or something like that.
Yes.
But yeah, so if you're in the New England area, and if you live in a New England state and your state school doesn't have a program, I think it allows you to go to another New England school for something like in-state tuition.
Exactly. I think it was in-state plus half, and it was great. I think there was other kind of variations on that program, but they didn't have healthcare management policy. So
okay, so you knew right from high school that you wanted to do it, and so you matriculated into the program into the school as a major. Okay, great.
Yeah, and I understand that, and you will be teaching 401, but I do understand that that's where a lot of students do recognize that this is a great field and a great place to be. But no, that I came in starting off with this was my major, and this is where I wanted to be.
Neat. So I saw that you did your internship at Beth Israel Hospital in Boston. So HMP majors are required to do an internship. Was this back in the time when you did it in the summer, or were they still doing it during the year?
Yeah, no, this was absolutely, it was during the summer, so it was a 3-month, just like it is today. And I happened to know a nurse because I worked at Anna Jake's, a nurse in the ED. I worked at that time as a unit coordinator in the emergency department. and she had known someone who knew someone, and basically it was one of the VPs at Beth Israel Deaconess. She made a contact for me, or a connection for me, and I was able to, kind of get a internship at the BI. And one thing I always tell my students when I take students is it's really about the networking. So it's really working your networks, asking people and making those connections. So it worked for me. So I went to the Beth Israel, and it was before it was Beth Israel Deaconess, which it is today, and it was a great organization. Some of what I did was I worked with the associate vice president for operations. I've talked with him over the years, here and there, and he's kept me up to date. He was great. He just kind of gave me a real perspective of what leadership did. I did things like helped with some disaster planning for Joint Commission, and I'm thinking back, it was almost 20 years ago.
Yeah,
it was
sure.
Quite a long time ago, but it was a great experience, and he really just tried to bring me in and give me all of the information I needed. I attended a lot of meetings, but got to see a lot there.
Yeah, great. That sounds like a great experience. So how did that shape your future kind of goals and plans?
Yeah, I would say that shaped it a lot. I think operations is something that's so important to healthcare, really trying to do things better with less, more efficiently. It really resonated with me. So, going in and kind of viewing what they were doing with operations, it included space planning, facilities. Where do we want to, we had a location in Lexington, I think we had just opened. They were building the Shapiro building in Boston. They were looking at a merger. I was semi-aware of some of that. But it really kind of helped me understand, what was happening in healthcare. So I would say that was, absolutely, formidable for me in terms of really getting some, solid experience. And I think, my last role at the Joslin was VP of Clinical Operations, which really linked to, that role there. And, I think everything we do as leaders in healthcare has that link back to operations. So it was just a superb experience.
That sounds great. I have to mention quickly here that you received the 2015 Preceptor Award from the department, from my department, from HMP, for your support of the internship programs here at HMP. So thank you for that. And we'll talk a little more about that maybe at the end of the podcast. So you graduated from HMP, and then you went off to Iowa. And in Iowa, you earned your MBA from St. Ambrose University. So what made you decide to pursue an MBA, and why immediately upon graduation, and why did you head off to Iowa?
Doesn't everyone do that?
Well, that's what I've heard. And all the kids are doing it.
So. To Iowa. Well, I happened to meet this gentleman. I don't know if I'd call him a gentleman in college, but anyway, I met someone in college, happened to be my husband. We met at UNH.
Okay.
I met him my sophomore year.
Okay.
He happened to be graduating, I think he graduated my sophomore year. He was playing hockey. I played at UNH and was playing professionally. Oh. So he had gone out to Iowa, and he was, moving out there. At the same time, I was in the midst of trying to figure out, is it the right time for me to go back for my master's, or, what should be my approach? And, I advise students now that probably some experience is probably the best, way to go. Not what I did, but it was probably the best way to go. Mm-hmm. I followed him to Iowa. And he did propose first. So for anyone listening, for any of those young ladies, he did propose first. So I did have a commitment, but I did follow him to Iowa where he was playing. And I started interviewing. And I think Iowa was in a different place from a healthcare perspective. And they didn't recognize who I was and what I was trying to do. So I think in the Northeast, I understand someone coming out of their undergrad, I understand what experience they need. I had some experience, probably about 4 or 5 years of experience as a unit coordinator, transport tech. I worked at New England Healthcare Assembly, some of these other places. But no one knew what to do with me. Okay. They were kind of trying to figure out, should she be a director? And I was at the point where I would wash the floors in a hospital for they'd just give me a job so I could prove myself.
Okay.
I just wanted, to prove myself.
Yeah.
And I really couldn't find a job. So I was actually out for a year.
Okay.
Trying to figure out where to go. I had talked to some folks. St. Ambrose was one of the nicer colleges out there, and had talked to I think it was the dean at that time, and met with him. Really liked him. It was a 1-year executive program. Okay. So I waited tables for a year, and decided that I wanted to go back to school, and if I couldn't get a job in my field out there, where things were it was at a different time. People didn't quite understand what to do with me, that I could maybe go back to school. So that's what I did. I decided to go back. I went back for my master's in business.
Okay.
I didn't have a healthcare
What?
concentration.
They didn't have that available?
They did not. It was
Okay.
a straight MBA. I think they introduced concentrations after.
Okay.
But I would say that it wasn't a problem. I actually have advised students, if they go back, going for the straight MBA, it gave me a different perspective, and I think it, broadened what I can do, in my career. So I've obviously opted to stay in healthcare, but I think that opportunity to, kind of branch out or really understand kind of other aspects of business
Right.
was really complimentary to my undergrad, my solid undergrad. And I think we learned so much about healthcare management that, broadening that with that business degree was probably good for me anyway.
Okay. So you got the business degree, and so shortly after graduating, you took a position at the University of Iowa Hospitals and Clinics in Iowa City as an administrator for the cardiology clinical programs. And so for those of us who are not familiar with the University of Iowa Hospitals and Clinics, can you kind of briefly describe the organization and where did you fit in that position in the organization?
Yeah, it's a large academic medical center. So the University of Iowa obviously has residence training. They have dental school. They have an affiliation with the VA. They're a good size, and I couldn't tell you the number of beds today, but a good size organization, full complement of services they offer from, OB, maternity to, geriatrics. They offer, all services. The Department of Medicine had, a division of cardiology similar to most academic medical centers. I worked for the clinical medical director for cardiology. My role was somewhat like a practice manager. I didn't have a whole lot of supervisory experience. I would say it was co-supervisory. This was a new position for them. They were trying to figure it out. I would say I did a lot of business planning, trying to figure out, we had a poor match one year, so trying to figure out how do we staff. We brought in nurse practitioners, which was new, nurse practitioners and PAs to try to, continue to staff at a level that we needed. We looked at some of the programs in our clinic and identified more efficient ways of delivering care through pacemaker clinics and that kind of thing. So it was a lot of business analysis, which was a lot of fun. And I would say there it really got me some exposure to billing. Okay. CPT codes and billing and financials, which I really think is a nice solid basis for anyone getting into healthcare. Obviously in undergrad we learned a lot about that, but here it gave me the opportunity to really kind of put into practice and start analyzing some of those numbers and really digging into them and understanding them. And I think that was probably what I learned most from that position and that role that really helped me as I progressed in my career.
Okay, and you did. So in 2000, you worked in the cardiology program there in Iowa till about 2000, when you returned to New England and took a job at Brigham and Women's as the associate administrator for the Department of Medicine. Can you talk a little bit about Brigham and Women's and then kind of how the Department of Medicine fits into that organization?
Yeah, so the Brigham and Women's is obviously a very large force in Boston healthcare and Longwood area. The department, another academic medical center, Harvard affiliate. The Department of Medicine is one of the larger departments. I worked for the vice chairman of medicine. I came in and, I think the interview process was interesting, and I have to give a credit back to the University of New Hampshire. Really, it was through the listserv that Chris Hammond, who, she does it and she continues to do it. She's wonderful. Right. I think she had sent out an email to the listserv, and it was from a colleague of mine, Erica, who I had talked with about her internship. She was a couple of years after me. And again, it's all about that networking. And so she had sent something out. I think there was a practice manager job at the Brigham. And so I reached out, I think, to Erica and said, what do you think about this? And, I used it as an opportunity to get home to Massachusetts, New England. And I got an interview, of course, and I think that's again the value of the network. And through that interview, I met with Sue Gilley. She headed up the practice managers at the Brigham. And what happened was I was able to meet with the vice chairman. Sue said, you've kind of done this job. You've been a practice manager, but I'd like you to meet someone. So I met the vice chairman. And it was that day, and I think my mother had come with me, and she sat in the lobby. She had driven me in and sat in the lobby, and the interview was supposed to be maybe an hour, and it lasted 4.
Wow.
So Dr. Brown, Monty Brown, had said, well, I want you to meet with this vice president and this person and this person. And so I thought, wow, this is great. So there was no job, but he just wanted me to meet with these people. So I met with a lot of them, and I think I flew back on Sunday. By Wednesday, I had a job offer. They had created a position.
By Wednesday, they had created a new position.
Yeah, a new position. This just speaks to Dr. Brown. He had created a position, and I had a job offer and had to make a decision, do we uproot? My husband was at the top of his career in the Quad Cities. He was our all-time leading scorer, and, uproot, this was a great opportunity for me, and what do we do? And we did decide to go back to the Brigham, and I worked with Dr. Brown for a number of years, and I think he was the one I probably learned the most from in my career.
Okay.
I don't know if I've ever told him this, so maybe he'll listen to this
We'll have to
podcast
send
someday.
him a link.
That's right. But, I think he was just such a good teacher, and, that's part of being in an academic medical center is you really do get that. You get people who like to teach, who like to, help, and he always gave me the frame. So when I was, when he was giving me a project or something that I needed to do, it was framed. So I knew when I went into something, I had all the facts that I needed so I could make an informed decision. So I'd say as a leader, as a mentor, that's something that's always stuck with me and resonated with me, and something that I try to, give back and do that. The other thing I learned from him is, just make it happen. The example of him creating a job in 3 days, and, interviewing with pretty much everyone and, administration there, and get it done today. Let's not wait and schedule, and let's just, kind of make it happen. So, really learned a lot from him. And, the Brigham was a great place, learned a lot there. And over time I was promoted to work for the chairman of medicine. And he works, I think, for the Institute of Medicine right now, nice. But he's just a force in the field and very knowledgeable and kind of a real thought leader. So he learned a lot there.
That's great. So for folks who are not familiar kind of with the structure of what's in the department, what falls up under the Department of Medicine?
Great question. So similar to Iowa, so I'm taking for granted that folks know kind of academic
Some
medical
do, but,
centers.
But let's just throw that
But
quickly.
I think that's a great question. So oftentimes, most times in the Department of Medicine, I'll list a few. So you might have, one of the big departments is cardiology. So cardiology would be in medicine, cardiothoracic surgery, or cardiac surgery would be in surgery, in the Department of Surgery. Oftentimes things like infectious disease, rheumatology, gastroenterology, pulmonary, neurology. But most of those medicine-type services where there's no surgical intervention, no surgery, would be in the Department of Medicine, just kind of a nice way to think of it. And I'd say that's pretty traditional in most academic medical centers in terms of how they structure their departments. And usually that's dictated by the training programs in terms of, for us it was Harvard, at the University of Iowa it was University of Iowa, but how residents and trainees and interns come into the departments and how they train.
So they had a number of residencies at Brigham.
Yes, very big interns, residents and fellows.
Okay.
Very big program.
Okay. So the job took you back to New England. I was going to ask you if maybe it was again your husband
took me out,
but you took him back.
I think he frowned the whole time, but we made it back.
Well, that's good. It's a partnership, right? While you were at Brigham, what kind of leadership responsibilities did you have?
I'd say, there were financials and budgets and, more business planning.
Okay.
My role there was really that of, you might call it a business planner or internal consultant, where he would find opportunities. And I think this was the beauty of the position, where we needed to, kind of really dig in or understand. And the leaders or managers in those departments were probably busy with their day-to-day and didn't have the time to step back, but recognize that there might be some opportunity. So for me, I had the ability to go in, do the analytics, work with him. I mean, he had, given me a ton of direction, make some recommendations and then implement those. So for me, it was an opportunity to see. I think I did stuff with GI, with endocrine, with cardiology. I did things that span the course of the entire Department of Medicine. So it was a real experience for me to be able to see a lot of those different departments. In terms of supervisor, I didn't have a whole lot of supervisory experience, but enough so I had some experience, and I think that's probably something he did consciously to give me that, experience so I could grow in my career.
So you stayed there till 2002 when you moved to another Boston hospital, Boston Children's, to be the administrator for the Department of Cardiology. So back to cardiology again. Mm-hmm. Can you talk a little bit about the mission of Boston Children's and the mission specifically of the Department of Cardiology?
Mm-hmm. Well, if you listen to the radio in Boston, you'll know that the Boston Children's mission is until every child is well. It's changed since I've been there, but it's basically been about the same. It's an amazing place, as are any of the organizations I've worked at. Children's is an amazing place, amazing leadership. I was looking for something where I had more, autonomy, where I could exercise my supervisory, kind of experience, where I could really grow. And Boston Children's in the administrator position really gave me that. I worked with the vice president for patient care services, our cardiovascular services. Her name's Patty Hickey. She was a nurse, and she's just recently achieved her PhD. And I worked also with Jim Locke, who was the chairman of medicine there for some time, and also the chief of cardiology. And really, I think the thing about Children's was that there was just a passion for the children that we cared for. And I think, there's a big nursing presence at Children's Hospital, and it really shows in that there's such a tie back to the patient and family and the experience, and things we did like parent presence, or that they did on the units. How do you engage with parents while you're treating their children? I remember walking down the hall one day and seeing one of my doctors who looked a little bit, distressed or downtrodden, and I said, "What's going on?" And he had just spent the night with one of his patients. So it's just that real caring and being in a place where there's just such a commitment to the patients. And so it was a great feeling, great place to work.
Yeah, neat. So that you started to kind of answer my next question, which kind of rotates around. This is now your third hospital that you've seen. Can you...
Fourth, with Anna Jakes.
Yeah. Sorry, yeah, so fourth, right. And really, I guess maybe fifth, because you came back
at the
from
BI. Yeah, there's
BI,
gosh.
So you've started to accumulate some organizations, in your experience. Can you talk a little bit about kind of maybe some of the differences that you saw between the organizations? Like you talked about kind of what really stood out in a positive way for Children's. What were the...
Yeah,
what are you starting to learn at this point in your career about the differences in the organizations?
Looking back, I can learn more. While I was going through it, I was just trying to get through day to day and trying to figure it out. I think looking back, in Iowa, it was a big organization. It was some time ago, so it's kind of hard for me to, really recollect, my experience there. I was, in a position where I didn't have a whole lot of purview. I was kind of doing the day to day. I think as I've grown in my career, I've been able to see more of the strategy. I think at the Brigham, it's a big organization. It's hard to make things happen. Children's was a little bit smaller.
Okay.
I think rallying folks around a single mission is a bit easier as you get into a smaller organization. I think I mentioned the nursing presence. That's something that's really important. I worked incredibly closely with, there was a colleague of mine. I talked with her this week, and she happens to be the goddaughter of my child, and she's the director of nursing for cardiovascular services there, and we really formed this partnership. So, as the administrator, I think it's important to form those relationships and those partnerships. I don't know about clinical care. I will never know about clinical care.
Right.
But it's important for me to round that out. So if we look at, where our blind spots are, that's one of my blind spots. So forming a triad, I think, as an administrator, so having your nursing leadership, your physician leadership, and administrative leadership, really come together around that vision and mission is important. So I think, as I've, progressed in my career, I've recognized, those partnerships that need to happen, and how do we work together, really form those. And, just to kind of fast forward to today, I think that's something that's really happening here in my current role, and we'll talk about that more, I'm sure, in a little bit. But that's something that's really important and really something that I can take away from Children's in terms of, the organization, how it works. There was a transparency at Children's. It was smaller than the Brigham, but it was still a good size. You could walk through the halls and you knew a lot of people. Another thing with Children's was at the director level, I had a lot of colleagues that we started different initiatives, and really, again, working together with them to get things up and off the ground, really resonated throughout the organization, and they really allowed that and supported that. So, for example, the internship program. So we worked closely with UNH, and we tried to be agnostic, and we did work with others, but UNH obviously had the best students.
Obviously.
But, we worked together to really rally the other directors and find out, how many students did we need. And I'd say, working with my colleagues, we put together a book. It was their vision, but, being part of that, I think there was 3 of us. putting together a book about what we needed to help out for the summer in terms of internships and being able to advertise those, bring them in. We did round robin interviews, and those still happen. So this is still ongoing, which is, really exciting for me. But I think the fact that we had the autonomy to do that at Children's was something that was really great. And I think, something you and I might have, talked a little bit about was management grand rounds at Children's.
Yes.
So that really, blossomed out of, my colleagues and I being at a conference. MGMA, happens every year. And
MGMA is what?
Medical Group Management Association.
Okay.
It's a professional association where they try to, bring education and new learning and teachings to administrators. And we happen to be there, and usually happens in the fall. And we would break up, and different folks would go to different sessions, and we'd come back and meet after them and try to talk. This is what, I took from this, and it was a great learning opportunity to learn from one another. And we started talking and thinking, we have so much of this knowledge at Children's and in Boston, in the Longwood area, that we could start tapping into this and promulgating this information out throughout our organization for folks that, maybe report to us, and, we want to help them grow. So Grand Rounds is typically something that medical folks do, where they, try to take a topic or something that they've learned, and they, bring that to their colleagues so they can all learn. Maybe it might be research on a certain topic, or some, something they've investigated the research, or they've done their own research, where they bring that to their colleagues so they can learn and, implement that in practice. So we felt like, well, we could have a management Grand Rounds. So we started management Grand Rounds, and we started asking, for one, the folks that worked at Children's. So we had a wealth of knowledge at Children's, and half of which could have taught these sessions, that we were at. So we started integrating them. And then in addition, there's folks, we were right next door to Harvard or Northeastern or, a lot of these other organizations. And, a lot of us had a number of connections. So we started bringing those folks in, and it was a brown bag lunch. We limited it to about 40 participants.
That's good size, though.
Yeah, we would pass out or hand out if there was handouts beforehand. And I have a feeling, and this was probably, at least 8 or 9 years ago, I think it's still ongoing. And it really, brings for, maybe someone coming out of their career that's in an entry-level position but wants to continue to grow. It doesn't cost a whole lot to the organization. It's lunchtime.
Right.
These folks do it on their own. So and again, it was something that we had as, administrative directors that came up with, and the hospital supported it and supported that effort and that initiative. So that just speaks a little bit to Children's.
Yeah, what a great initiative. I mean, that's a great way to learn and learn from each other, and it's low cost and networking.
And it really helps the folks that work for us. I mean, they learn, and they can, now they know what I think I taught a session on capital budgeting, and we had someone, one of my doctors has a wife, Linda Hill, who's just a brilliant, business professor at Harvard, who came in, and she just an amazing session. Or we just had some Clayton Christensen's colleague came in and taught us about that. So just some big names and nice connections and nice learnings.
Nice. So the title of your position was administrator. What did that mean? And then also in 2007 you were promoted to administrative director. So what was the administrator? What was the administrative director? What additional responsibilities did you take on when you became the administrative director?
I would say that I came in as the administrator. Cardiology was a good-sized department in the organization. And this was one case where the Department of Cardiology did not fall under the Department of Medicine. In most academic medical centers, as you probably know, Mark, cardiology is a division of medicine. And I mentioned that's the way it is at the Brigham, and that's the way it is at Iowa, that's the way it is at the BI. So most academic medical centers, that's the case. In cardiology, it wasn't the case. So I had the administrative responsibility for our department. So it was a little bit different than a division. So I think at some point throughout my career, at Children's, that was pretty much, I think it was a recognition for that. And I think that's why the title changed.
Okay.
So I think it was more of a realignment with HR and that kind of thing. The job was, I would say, very broad. And I learned just so much. The departments at Children's are, for the most part, they're separate 501c3s. What does that mean? That means that they each have a nonprofit status. So the Department of Cardiology for the physicians has its own 501c3 and it has its own nonprofit status. So if you looked up on guidestar.com, for example, they do a separate filing for their own entity. It's a separate
so
accounting.
They're actually separate entities within
separate,
children's.
Exactly. So there's 17, there might be more or less, but there was when I left, 17 foundations, we used to call them the foundations. And what happened was, I think they broke them out in the 1980s, and it was kind of changes in healthcare and the recognition that, to break these out, it was probably fiscally better and, made more sense. So they stayed broken out. And so, for example, the Department of Medicine is a foundation, Department of Surgery is a foundation, urology, I think, was its own foundation. So these are all different, anesthesia is a foundation, they're all different 501c3s. The benefit of that for me from a learning perspective was I got the opportunity to work with, we had a accountant, I worked with her, we did our own billing and collections, and that was all kind of rolled up under me. And I learned a lot about benefit structure, so the defined benefit, the defined contribution, pension plans, we had a severance plan, worked with attorneys on all of that, we had tuition plans. So all of these plans and benefits that fell under the foundation gave me the opportunity to learn about that. I was also responsible for the professional billing for that foundation, for all the doctors, all of their billings and collections and that kind of thing. That rolled up under me. So I had the responsibility of doing that. And I think when I go back to the University of Iowa, where I said that was some of the underpinnings that, really helped me understand the financials and how healthcare works, I would say that's what really kind of teed me up for the Brigham job. Because when I went in there, I was doing a lot of the business planning and going into different departments and that kind of thing, and also gave me the, kind of benefit in terms of going to children's cardiology. So a lot of the billing on that side. I was split 50-50, so 50% of my time was on the foundation side, and I'm talking with my hands right now. Folks on the podcast can't see that. But just trust me, it's happening.
Yeah.
So, you would see the foundation side, but there was also the hospital side. And so 50% of my time was spent on the hospital side, working with that nursing director for the cath lab and, our echo lab, EKG, so all of the hospital provided services. So that was some of, my responsibility there. I'd say in terms of the title change, it wasn't a big change. It was probably more in just
to give you appropriate status for what you were actually doing.
I think that's probably what it was,
Okay.
yeah.
Okay, That's really interesting. So one of the things you noted you were responsible for was the oversight of philanthropic funds. What's the difference between working with kind of standard revenues coming in and philanthropic funds?
That's a great question. And again, it was another great opportunity to work with some philanthropy and understanding that. Philanthropy is so important to healthcare. And Children's just does an amazing job of really integrating philanthropy and recognizing that it really has a place. I think another place that does that is Dana-Farber, in terms of the PMS Challenge was just this weekend. And, these are things that help us in healthcare fund maybe initiatives, programs, services that are not otherwise funded. We have limited resources that come back for the services we provide, but philanthropy allows us to maybe, I think it was today I was reading the Sunday Globe, I was reading it this morning, but for example, at the Beth Israel Deaconess, they've identified a program in terms of patients in the hospital and really integrating them into the decision making. So a patient kind of commented that she was in a bed next to someone and had this terrible experience because this other patient was undergoing maybe some kind of a code or something like that. So using philanthropy to identify, what are the problems and study that, they used philanthropy to do that and try to improve that. So philanthropy is really important to the services we provide. The funds are a little bit different in that a lot of times they're earmarked for certain programs. So at Children's, in most places, there's unrestricted funds, so funds that come in and someone just says, I want this to help the Department of Cardiology. Might come in and say, I want it to help the hospital or organization, which would be a broader use. It might be restricted to cardiology. It might be restricted to something as small as the echo lab. So using those funds appropriately and understanding where they should be, so they might be current use and I can use those right away. It might be restricted in that I can use just a certain amount that spins off. So like your bank account and my bank account, We do earn interest oftentimes. You can't really tell, but they do earn interest.
It's pretty small these days.
It's pretty small, right? But the folks at Children's do a great job of investing their philanthropy and their invested funds, and it does spin off some dollars that they can use. So, for example, an endowment, you can't touch the principal and the amount that's in the endowment. You oftentimes need, about $3 million to get an endowment going. And it's not like you need someone to write a check for $3 million, but it's that pledge to have $3 million over a certain period of time. That spins off so many dollars, and those are the dollars you can use for that specific reason that the endowee, or I guess the person initiating the endowment, might dictate. So philanthropy is a little bit different.
Is that what drives the separation of the departments at the hospital? Was that part kind of why? Or?
No, it's a great question. I think the chiefs like that because they do have that autonomy.
I see.
However, I would say the thing that drove this separate was billing. So billing for services, and I don't have the exact dates, but there's the ability to split bill. So, and we do that here at the Elliot. So insurance companies still allow you to have the hospital submit a bill for, so let's use an EKG, for example, an electrocardiogram, something that measures the waves in your heart and kind of reports out to the doc. There's two components to that. One, it's the tech who uses the EKG machine, puts some electrodes on your chest, and they measure your waves. I'm probably horribly describing this, but that's about what happens. And then there's the other piece where the doctor interprets it. There's two separate bills for that. There's one for the hospital and there's one for the professional. And years ago, what happened was this was allowed, and there's a way to submit these separately. Same thing with a visit. So if a patient comes in for an office visit, there's a way that a separate bill can be submitted for the visit for the hospital, and the doctor doesn't have to pay rent. What happens is the hospital collects or gets their dollars back through that technical fee or that technical reimbursement, and the doctor submits for his or her time, and his or her staff, he submits a bill or she submits a bill, and they get paid. So this is why the foundations were formed years ago. I think it was the 1980s. Now, children stopped with the split billing, but they kept the foundations separate. So I think that was the impetus, and the Brigham had done that, and they were bringing the groups back. The other thing is the 17 foundations got together to form a physicians organization. That physicians organization does the contracting on behalf of the physicians, and they also do a lot of the healthcare and benefits, some of the kind of benefits that they can share together. They do a lot of that contracting for them as well.
Okay, interesting. You were very busy at Boston Children's, working very hard to do all the grand rounds and all this other interesting things. And at the same time, in 2009, you earned your doctorate of law and policy from Northeastern University. So, not enough to just go to work and do all this other great stuff. You were also going to school at night, I assume.
It wasn't at night, actually. This was an intensive program. So what they would do is they would do weeks, and then it was weekends. Okay. So kind of like night. Okay. I didn't have enough to do.
Part-time, yeah.
Yeah. So it was a program. It was an amazing program, and it was a new program at the time. I was part of the first cohort, and I would say it was being around all of these academics and folks who wanted to really better themselves and wanted to continuously learn and, challenge the status quo and, kind of find out, there's something that I don't believe or I don't understand, so I'm going to research it. So it really gave me that kind of yearning myself. So professionally and personally, I felt like it was, time for me to do something like that. And again, I think it was working with all of the folks I was working with that really kind of gave me that impetus. I went in, and this program was really interesting. It was a program where you come in and everything you do really builds toward your final thesis. So I went in pretty much with, kind of basic thought about what I wanted to research. So my job at Children's saw patients with congenital heart disease both at Children's but also at the Brigham. A lot of our docs went over to the Brigham, which is the adult hospital connected by a bridge. And it dawned on me at one point that, as we rolled out electronic medical records, that there was some downfalls to that. It was great, and I'm very much a proponent of medical records and think it's so important for what we do, but we need to do it right. And if we don't do it right, it's going to cost us. So I'll give you an example. If I have a procedure at Children's And why would you have the procedure at Children's? Well, because you have congenital heart disease. Most of the docs over at the Brigham are more familiar with acquired heart disease. Over time, adults, acquire heart disease. Their hearts aren't as working as well as when they were young, and they're more familiar with that. But at Children's, that congenital heart disease is a little bit different. Your anatomy isn't structured the same as it is when you're an adult or, with a normal heart. So the folks at Children's really were familiar with that congenital disease, and when they were doing diagnostic testing or doing procedures, all of the techs, all of the docs, all of the nurses really understood that. So a lot of the procedures and diagnostics were done at Children's, but when you're admitted, you go to the Brigham because that's an adult hospital. They have sheets that fit you and Johnnies that fit you and beds that fit you. So I'm making that up. But if you had a comorbid disease or something like that, they would be more more capable of treating you as a whole person.
Okay.
But it dawned on me that our electronic medical records didn't talk to one another. So because they didn't talk to one another, I wondered, if a patient has testing, labs, EKGs, echoes, and just various kind of services at Children's, when they go over to the Brigham, they need that information to treat them. When it was in a paper file or paper chart that kind of sat on the bed next to you when you went back and forth across the hospital, it was all there. But what happened when you went into the electronic medical record at the Brigham after you had been at Children's and you're looking for that EKG or those labs or whatever? Are they going to be there? Are you going to look? You look in the labs where the discrete data is. It might be scanned in somewhere else, but it's not going to be there. So I did. That's what kind of I wanted to do, and I went into Northeastern, knowing that was something. And I think there was a lot of focus on theory and trying to understand, how do you get your point across, and how do you find those blind spots, and in your research and creating policy and that kind of thing. So I was able to really focus on something that was important to me. I was also able to be in a class where, I remember my first class, I felt so inadequate, where, I probably was the second youngest in the class, and, all these folks had this, rich history, and they had just been around longer than me, but over time I recognized that I really knew my field and my industry, and it gave me a little confidence. But it was a great program, and it gave me the opportunity to really study something that was important to me.
Neat. So after 8 years at Children's, you were hired by Joslin Diabetes Clinic as the Vice President for Clinical Operations. So briefly, let's talk a little bit about Joslin and what's its mission, and how is it different from the organizations you had worked with previously?
Joslin is a center that's focused completely on diabetes, treating the whole patient with diabetes. Our mission and vision is really to put ourselves out of business, or was to put ourselves out of business. It was to really find a cure for diabetes. But while we were doing that, it was to treat the whole person with diabetes. It's not just the endocrine system, it affects other systems. My role there was a little bit different than Children's or any others, because it was just so subspecialty focused. But it gave me a good opportunity to, kind of move beyond cardiology. I had been so focused in cardiology, and my concern in growing in my career was I didn't really want to pigeonhole myself just in one department. And this gave me an opportunity to kind of break out of that. Diabetes is such a big problem in society today.
Absolutely.
It ties to so many other kind of comorbid diseases. For example, a lot of people who don't have diabetes don't recognize eye disease, kidney disease, neuropathies. So there's so many kind of other aspects of diabetes, behavioral health. There's a huge component, and I think about, imagine being a teenager and going to college and having a pump, or, having to inject insulin, having a pump, to inject your insulin, CGM, testing your blood sugars. You're already awkward enough, going into college or even high school, but, to try to understand what this means. So for the family group to come together and, to really understand that behavioral health and social work are really important components of that. Urology is another kind of aspect of cardiology, vascular diseases. So I'd say, Joslin is just really deep in diabetes, which was different than, some of the other places I had been. It did give me the opportunity with these subspecialties to understand a bit more about ophthalmology, urology, education, how important education is, nutrition, and just general diabetes education. Really, kind of learn a lot more about endocrine. And again, the mission of Joslin is really, to treat those patients with diabetes in all aspects of their care.
So what were your responsibilities as the
Vice President of Clinical Operations?
Vice President for Clinical Operations?
Yeah, my responsibilities were to oversee, I would say, all of the administration for clinical operations. So what does that mean? That means if we were going to bring in new programs, those were something that I would need to look at and investigate and understand. It was compensation for the physicians and providers. What did their compensation model look like? It was working with payers. We did a lot with payers to try to look at other innovative programs that we can work on together that reduce overall costs in healthcare and maybe introduce diabetes care earlier. An example might be if a patient goes into the hospital and they go in for a heart attack, but they have diabetes. They might stay longer because they have diabetes. So we focus on treating the heart attack, but there might be, getting their diabetes in control. So the heart attack's first, and then you kind of look at the diabetes. Well, that might extend their length of stay 2 or 3 days. That's an expensive kind of situation. So how do we introduce that consult or that diabetes intervention earlier in the stay? So how do we do things like that? We were doing a lot with telemedicine, for example. How do we introduce telemedicine? And it takes a lot to manage your diabetes, and going into a organization 4 times a year, how do we make it more convenient for our patients? The patients with diabetes are dealing with so much already, and how do we make it easier for them? Revenue cycle rolled up to me, health information management rolled up to me, education and all of the subsections at Joslin also rolled up to me as well. So I'd say it was a broad swath. Anything administrative kind of rolled up under my purview. And I worked very closely, obviously, with the chief medical officer to, roll these programs out, as well as my directors and managers.
Wow. Okay. So you were saying you worked with chief medical officer. Where did your position fit into the overall organization?
Mm-hmm. So I reported up to the chief medical officer.
Okay.
I sat on the senior leadership team, so I had the ability to be part of the decision making, help influence that, bring things that we might be doing at a senior leadership level down to the clinic, helped with strategy. I mentioned some of the programs and things that we were doing. I also took on some other areas. So Joslin had an affiliates program. So about probably almost a year, 6 months before I left, I took on the affiliates program. The affiliates there were about 40 affiliates of Joslin throughout the country, and what we did was we were probably one of the places that took care of the most patients with diabetes. So we learned a lot about how to do it well, and it was this kind of, it's a PDSA cycle on steroids. You learn a lot fast. So how did we take that, and this was back 26 years ago, someone kind of came up with this concept, how do we take the lessons that we learned there, policies, procedures, everything else, and help organizations that are really trying to implement a better program for patients with diabetes? So those were our affiliates. So they would pay some money, and we would work with them. We'd have site visits, and we'd help them implement new programs and help support them in their role in their delivery of diabetes and diabetes programs. So that was another kind of aspect. We also had affiliated programs. So we delivered a lot of education because, again, we knew a lot about diabetes. It was just this concentrated area. So we were taking our lessons learned and things that we learned working with, it might be pharma or industry, to help them educate their specialists or their salespeople or maybe other clinicians. So we called it professional education. So educating other professionals in how to manage these patients. And in terms of, just to get back to, I don't know if I answered your question, in terms of leadership structure, I was responsible for that, sat on the leadership team. And I will say one other thing that our president did was he allowed us a lot of times to sit in on board meetings. So that was another great opportunity to really speak to what was happening in the clinic. Questions had come up. And, we sat on the periphery, but he would, kind of tap into us and say, okay, Bridget, why don't you answer that question? Because that's something you know most about. So it gave us that opportunity to, be part of that and, really understand and learn in that way.
So you started to engage with the governance of the organization at that time.
Yeah, I would say engage or just kind of, be part of it. Or yeah, absolutely, absolutely.
Well, that kind of leads me to my next question about this. So you'd been working in senior leadership positions up until this time, but now you have this vice president title. So what I hear you saying is you really kind of moved up to a strategic position in the organization. What are the implied responsibilities of someone at this level? So I mean, you have formal responsibilities, but my sense is when you move into the strategic leader level, you've got kind of a broader scope of responsibilities that go beyond perhaps what's on paper for what you are supposed to do.
That's a good question. Or, I mean, it's a good comment. Yeah, I would say, there's probably a lot to think of them right now. I'm probably not going to do a great job, but I'd say some of the implied, there's really a responsibility to the organization, to the staff. So one thing I felt was important was really to enhance communication. We were a small organization, but to really make sure, and I mentioned Children's did a really great job at this, and credit to Sandy Fenwick, who's their president and CEO now. But, really to make sure folks were on the same page. If we were doing something, how did they fit into that? If we were changing, rooms or space, or, it was small enough so they should know because it's going to impact them, but really to communicate. A lot of it was financial. We, financially, the Joslin has a challenging business model, but how do we engage staff in helping us achieve our mission? So, this is something that I can do somewhat as a senior leader, but really it's about rallying the staff around your mission and giving them the tools and the information they need so they can do their job better. So I think for me, the one thing I felt like I needed to do was, really be a conduit of, providing that information and data points that they could use to do their job. And I'm thinking, the person on the front line, if something changed for us in terms of reimbursement or, something at a national level or something we're doing, or there's an initiative, it's important for everyone to really be aware of that so they can work, strategically with us, and we can do that as a partnership and as an entity. Obviously there's things like fiduciary responsibility and those things that, I have to make sure that I'm, making, good decisions. But I'd say this is the one that really kind of resonated with me at the Joslin, was really to bring the staff and the team together.
One of the things that I've observed, and I've not worked in Boston, but one of the things I've observed, from as an outsider looking in, is Boston seems a bit like the Silicon Valley of healthcare. And when I draw that metaphor, what I mean is, in Silicon Valley, you see folks moving from Google to Microsoft, or, and back and forth around community, and it seems like the community is very fungible. Is that an accurate observation? And I'm just kind of looking at your career in particular, having moved through many of these organizations. Mm-hmm. Is that a common thing to see in the Boston area? Do folks move between organizations, or are you kind of an anomaly?
I think so. I think as you grow in your career, probably, you're looking to, progress. And, I think that's what I hope folks see when they look at my resume is, that it was there was growth. There was, a stepwise fashion. I'm very deliberate in how I do things, so that might be kind of how I did things. I do think that does happen. I know, I've had students that come to me or, go across the way, and, I'll use Sarah Abkowitz, one of the students that I had at Children's. She was my intern. She then went to, and she received an award recently for HMP. She's a great student and great advocate for the program. But she was at Children's Hospital as a student for me, went to the Joslin, started her career there. She was there for 3 or 4 years. Now she's at Children's again. And I think, when she told me she was going there, she was going to work for Jason Dupuis, who I also worked with, who worked for me as an administrative coordinator. And I think one thing I like to see, is it makes sense. I expect some level of commitment, and, I think I gave folks a level of commitment for some time. But I think that makes sense to, try to grow in your career. And I think, I know I want that for my students, for the folks who work for me, to help them benefit and grow. So I think it's acceptable. And I think, you will see that in Boston. And, it really is, believe it or not, I think about Boston, it's a small community.
Yeah.
I think that was the hardest thing about coming up here to New Hampshire is I didn't know a lot of the people. Going from Children's to the Joslin or Brigham to the Children's, it was easy. I knew, a lot of the people. I could make a call. How do you do this? How does this work? The politics were all the same. This has been a big learning experience for me, coming up to New Hampshire. It's different. I didn't know a lot of the folks. I had to learn a lot of things. Mm-hmm. But I think you're right. I think, you do see that, folks move around in Boston, and I don't think it's a bad thing. I think organizationally, it really helps the organization to grow.
Yeah, I didn't mean to imply that you were job hopping, because you did do a number of years at each position.
Sure.
Clearly, job hopping can earn you a reputation for a lack of commitment. But one of the things you're talking about in terms of the Boston being a big city, but it is a small community. I wonder you could talk about kind of networking and establishing a kind of a reputation in your community. Yeah. And how important is that?
If you talk to anyone, any of the students I've worked with over the past 15 years or whatever, I think that is so key. That's you've hit the nail on the head, is networking and really keeping those relationships, or supporting one another. I'll get calls. I have a call with someone on the way home today, on my drive home, that's trying to network with me, and you give back, you give to, and it's a to and from, and it's so important to kind of know who's on first and where folks are, and to help them. They're going to help you too, but I think you learn a lot. I connected with someone from Mass Medical Society the other day. We hadn't talked in a while, and she kind of saw I'd changed something on LinkedIn, and I learned so much from her and her job, and there's so much learning that can happen there. I can learn what's happening at Children's. I call up my colleague, and this is happening, and it might apply to us in what we're doing up here at Elliot. So I just think there's so many benefits of networking and really keeping current. And I think it's malpractice or not to do that. I just think it's so important.
Yeah. Is there a common culture shared by the healthcare community in Boston? Do you see an overlap between the facilities and the people there, or is it really they each have a unique culture and?
Yeah, that's a good question. My perception, and others, might have varying kind of perceptions, but my perception is that they are pretty different.
Okay.
I think it's really the leadership and the, clinicians and values and the mission that really do drive that. I think it's true. If you look at, Children's and how it differs from the Brigham, there's very much a difference there. The Joslin is primarily outpatient. However, we do manage the consults, inpatient consults at the Brigham. But I would say the cultures are very different. Knowing the players and kind of what happens in Boston really is helpful. But the culture, my impression is that they're very different.
Okay. So you worked at Joslin until just this past spring, when you left Boston and you headed up here to Elliot Hospital in Manchester, where you're now the Vice President for Physician Services. How did you decide it was time to make the jump from Boston? You kind of indicated it's a big jump.
It's a big jump, and I was very
even though
worried.
Manchester's not that far.
It's not that far, and my commute's not great, but it's okay from Massachusetts. But I felt like it was just time. I think at Children's I was there for 8 years, and I'm really not this old. And at Joslin I was there for 5 years, and I think I got to a point where at both places I felt like I had done a lot, accomplished a lot. But to be candid, it's time for a fresh set of eyes. Someone else who comes in and, I have that fresh set of eyes. I think, and I said this to my boss here, I think, folks, when they come in, that first year is when you really identify, things that need to change, initiatives that you want to start. How do you really impact change? And I think that's an exciting time. And I really, kind of get excited about that. And I think, here at Elliot, I've been here 3 months, and there's so many things I want to do. I just don't know how to do it all. I will do it all. But I think at Children's and at Joslin, I don't think that I was ineffective, but right. I think that a fresh set of eyes wouldn't have hurt them either.
Right.
So I just thought, from Children's to Joslin, it was a nice time, a nice transition, right time for me professionally. And I think the same thing at Joslin to here. And they just recently hired my replacement. He called me to talk about it, and, I've, left on just such great terms, and, they still call me, how do you do this? But I felt like it was time to kind of just make that move. So that's how I knew for me that it was time. I felt like, I wasn't as kind of coming up with as many new initiatives and, a lot of status quo, and I wasn't as fresh. So I think, moving once in a while from organization to organization, you can take your lessons learned, you can take some practices and kind of identify new opportunities in a new organization. The other thing was a gentleman that I knew of in the community. His name is Craig Williams. He was at Tufts New England Medical Center as the COO, and he had recently been hired at Elliot to be the COO at Elliot. And he had reached out to me via LinkedIn. Again, networking is so important. And over the course of years, we had talked. I didn't know him very well, but we had talked about, I think it was Jason who had interviewed at New England Medical Center, and Jason was great. And, we had talked about him, and I had sent him a note. He's a great candidate. But just those connections, he had reached out to me and told me about this opportunity. So the more I looked at Elliot, the more interested I became in the role, because there is a whole new senior leadership team.
Oh, okay.
So we have a new president who came from Elliot Health System in Wisconsin. We have a new COO. We have a new CNO coming, I think this week. We have a new CIO, came from the Boston as well. We have my position. So it's a really new senior leadership team, and I was a little nervous about that, but I'm really excited about it, and it's been a lot of fun. And I think as I walk around Elliot right now and talk to the staff, they're energized. There's this feeling of, kind of energy and excitement. The mission you had mentioned at Elliot is to inspire, heal, and serve. So I think that, this is a new mission. We've just recently rolled it out, and we're living it right now. There's an era of transparency from senior leadership. I think some of the staff are a little bit kind of, surprised about this, but it's an exciting time to be part of Elliot, and it's been great. And, working with the senior leadership team has just been a great experience so far.
Great. So kind of briefly, how big is Elliot? Well, give us a sense of scale and scope, or what does it do?
Sure. Elliot's a good-sized hospital. It's a community hospital. So again, this was a change for me being in, mostly academic. The size is, I think it's 300 beds. We staff to about high twos. I would say the strength of Elliot is really our community presence. So we have about, in my physician services network, we have about 340 or 50 physicians that are employed by the hospital. So we have a number of physicians, and then there's about another 300 that have admitting privileges here. A credit to the previous leadership, they recognized years ago that it was important to bring your network closer. So a lot of the primary care and specialist care that was in the community, they started to bring these practices closer to Elliot, and they became employed practices. So I think it was a vision, Doug Dean, the president before, and Rick Phelps. I've met Doug, I haven't met Rick, but to really bring the network closer. So the size of Elliot's is really quite large. I think the strength of Elliot is really the physicians and the network, and it's my role to really figure out, how do we align this? How do we structure it the right way? I'm working with my boss, the CMO. I have a dotted line to the COO, and then I report directly to the CMO, Chief Medical Officer, and working with him to try to figure out what's our communication strategy? How do we support the providers in their roles? How do we make their practices operate as efficiently as we can? How do we communicate our mission and vision throughout the network? And how do we get everyone to buy into kind of what we're trying to do? Our mission, our strategic plan really encompasses quality, which is important. So how do we promulgate that? It encompasses growth, sustainability, provider alignment, and employee engagement, and then patient experience. So that's really what we're focused on here at the Elliot.
You started to kind of talk about what your new responsibilities are. And you said you report to the CMO, the Chief Medical Officer. You said you have 350 employed physicians. So that's a very large group practice, right? So what do you mentioned the strategic goals just now. What do you do on a day-to-day basis? What is a day in the so far, 3 months you've been here, what does a day in the life of the Vice President for Physician Services look like?
So far it's been a little bit of everything. We've had some fires to put out, some things that this position was empty for about 9 months. We've been working through a lot of kind of the compensation, obviously, so working through some of the things that hadn't been addressed in some time. So I have some, great directors that I work with here. So working with them to, kind of help, kind of figure out where do we want to go strategically for compensation plans, compensation strategy, what's our philosophy around compensation. So that's been one of the areas. The other thing is before I came in, Dr. Baxter, my CMO, had worked with others to structure an operating board. So the network really has been structured, or there's been a leadership structure that's been implemented. So we've really been refining that. And the structure is an operating board, and under that there's subcommittees. So we have an operations subcommittee, which I chair, and that is really looking at, how are we standardizing, I'm giving examples, our primary care practices. How do we redesign that practice for the future? How many practices should we have? We've got, a number now, I'm going to make up a number, 15 primary care practices. Should we have 4? What should that look like?
What do you mean by you have some
satellite?
large
So
number?
if you looked at our practices, we might have a practice with 2 docs in it.
A physical building someplace out in the community
yes.
with just 2 doctors?
Yeah.
Okay. And you've got a bunch of these?
And we have a bunch of these, right. So what should that look like? Should we have, what's the right number? Should it be 10 physicians in a practice so we can gain those economies of scale and efficiencies and really provide them with the support they need? Or should it be 2? And how do you manage that small practice if you're trying to do that, knowing that they're under Joint Commission, accreditation and all of these types of things? So really trying to figure out operationally, how do we do that? It might be something like, how do we manage our labs in the satellites? It might be something like, what's our gift policy for providers? So it might be any number of things. The other thing aspect this operating board looks at is provider alignment or engagement. So we have 2 executive medical directors to roll out leadership and performance evaluations. Providers have commented that they don't get a lot of feedback on quality and that kind of thing, so working with them on that. A finance committee, so trying to engage them in the budgeting process and then engage them in if there's a variance, how do we understand that, and how do we dig into some of these kind of areas and try to work together and be transparent about what we're doing. And then the other is quality and safety. So how do we make sure that we're aligning our quality and safety with what's in our contracts, for example, that we're aligning with what our vision and mission is for the organization. So for example, if it's readmissions that we're trying to improve this year, how do we do that as an organization, as a network, and what are some of the initiatives we need, and how do we make sure that doesn't conflict with length of stay and our financial kind of interests and that kind of thing. So really working, I guess it's not a day in the life, that's a week in the life maybe.
No, right.
But that gives you a perspective of some of the things
Absolutely.
we're working on.
Great. You talked a little bit about some of the initiatives that you're undertaking, like quality. One of the big ones that we're hearing a lot with the ACA is readmissions. Kind of the latest buzz is population health. We're hearing a lot of. What kind of efforts is Elliot working on in the system? How are you cooperating with other organizations on population health, and what are the economic incentives that are actually out there to encourage and engage you guys?
Yeah. So if it's okay, I'm going to go back to Joslin, because I think that's where I learned, so much. And obviously a lot of what we're doing here at the Elliot is around, one of our quality initiatives this year is around diabetes. But I think, if I look at population health, I think of diabetes and, this being one of our biggest challenges. And as I worked with Joslin, we started engaging with payers and trying to understand, how do we together find ways to reduce the costs? And it might not be a patient coming into, I mentioned telemedicine earlier, it might not be a patient coming into the organization 4 or 5 times, or if they're having some challenges or need a little re-education, they're having some, in diabetes you have highs and lows and you're having some challenges, or maybe you've implemented a new exercise regime and you need some, education on that. Does it make sense for a person to take, think about it economically, 3 hours off of work, 1 hour so they can drive into Boston, 1 hour so they can have a visit, 1 hour so they can drive back, maybe it ends up being a day off. How do we incentivize patients to keep themselves healthier, right? And really take control of their care? So I think one thing that we were doing at Joslin, and again, it was really focused on diabetes, so we really had that luxury of doing that, was really looking at working with payers or insurance companies to incentivize the right thing. And what we started doing, we had an initiative with Harvard Pilgrim where we started doing televisits. So if a patient was having a challenge, something like that, they could have a televisit or a phone visit. Now that's something right now we're not paid for. As a health care organization, we're not paid for televisits or kind of Skype-like visits. But to be honest with you, we can keep someone out of the hospital if we're seeing that that's the case. Another thing we started using was some technology where a case manager in the office could understand what was happening with a patient. Because a patient with diabetes is oftentimes has a meter, or they have the data points where we can understand what might be happening. The case manager can look at that and she can understand where someone might be getting into some trouble. There's that outreach to kind of reach out to them and try to figure out, is there something going on? Is there some education you need, some help? We need an adjustment in your meds. Ultimately, to keep that patient from getting to the ER, where that's a $13,000 expense, and we can, try to really get to those patients earlier and keep them healthier, so they're living healthier lives. They're not costing the system so much. I think with Elliot, we're a large organization. We're not just focused on one thing, but we are getting into contracts where we're trying, and most places are, but the contracts do focus on that population health. How do we keep our patients healthier? How do we make sure we're, getting the colonoscopies they need, so we're catching, these things early on. Mammography is something else we're focused on this year. I think the challenge for us at Elliot, and most places, to be candid, I think at the Joslin we were just solely focused on diabetes, and we couldn't understand why everyone wasn't more focused on it. But the challenge is, for a large organization, there's so many different things you need to look at. Yeah. So we're starting to bite off small pieces. This year we're focused on mammography, diabetes, and asthma. Using a controller medication. We're going to focus on those and really roll out ways that providers can document, that we can monitor those and we can report on those. And I think that's how we're going to start looking at these. Now, obviously, these are baked into a lot of our contracts, so there's this financial kind of oftentimes upside, but that's what we're really trying to do at Elliot.
Great. So you mentioned, again, you're the vice president for physician services. You mentioned that, of course, physicians, like all of us, care about compensation. What else do you see as an administrator looking at, across the hall to the providers? What do you see what motivates physicians? You've been around for a long time, around them for a long time. What do you see? I mean, it's compensation, obviously. What else? What else motivates them?
I think data is something that's important that we have a lot of. I think presenting the data in the right way. So physicians are typically data-driven. They went through their career understanding data, and data is kind of what drives a lot of their decision-making in terms of practice, and having that proof that they're making the right decision through the data is important, but making sure that it's right. I think the worst thing we can do as administrators is provide incorrect data that's not been vetted. So I think that, providing them with that, giving them what they need to do their job, the tools they need. So data is one thing. Another thing might be staffing. They want to do a good job, so how do we help them? As administrators, how do I get them the tools they need so they can do a better job more efficiently, more accurately, more appropriately? And that's a challenge because you have competing demands. So if I provide more staff, it costs more. And how do I make the business case, if it's possible, that that's what we need? Data. There's so much data out there. I know coming to Elliot, there's so much. We're on a single EMR and it's wonderful, but getting the data out in a format that makes sense, that's been governed and, has been vetted through, that all of the data points are right, that we don't have too much noise, is really important. And getting that back out to the clinicians so they can use that in their day-to-day decision making is really important. So I think, as I think about it, and these are probably some of the things on my mind right now, but those are, two key components I think are really important to physicians. And again, they just want to, they want to make the right decisions and do what they can for their patients.
Okay. Well, let's shift gears a little bit and talk about leadership. What would you say is your leadership philosophy?
I would say that I like to engage with the folks I work with, my directors. I think I like, one of the things I mentioned earlier was the vice chairman who really kind of gave me the information I needed. In terms of leadership philosophy, I mentioned to you earlier the vice chairman that I worked with really taught me a lot. And I have to say, I think he taught me kind of most about leadership style. And, one of the things I think is important for me is to really give the folks I work with the tools they need so they can do their job. They need a broad perspective. They need information, data. They need details so they can make informed decisions. So I think the one thing I would say is I like to make sure that folks have that, good information. I feel that communication is important. I also like to, really bring in folks who complement one another and me. I don't claim to know everything. I'll give an example of at Joslin, I managed the clinical laboratory. I'd never managed one before, but I had a great manager and leader who, knew how to do his job, and, really listening to him to try to understand what were some of his nuances in terms of, leading his staff and really making sure that his area was successful. So I'd say for me, it's really giving folks the tools they need to do their job and supporting them. I will never, in front of others, reprimand or, kind of, if there's something that's going on that I disagree with, it's in a closed door, in a closed room with me and my director, and, we'll have that conversation and disagree there. But, kind of out in the open, we're always going to agree, and we're always going to have that, same perspective. So I think, support of them is really important, and giving them the information and the tools so they can have their own strategic framework about decision making in the organization.
What do you think are the characteristics of a good leader, and how do you aspire to those yourself?
I think a good leader is really present. Someone who's present. When I say present, yeah, they're around. They get out. They understand what's happening. They have a perspective. They're engaged. They're mindful when they're listening to the staff. They're mindful of what's going on. They're hearing, what the issues are. And I think a good leader listens and acts on things. I think a good leader can also say no. A good leader makes decisions. They don't leave folks hanging. They have the ability and the confidence, to make those decisions that are sometimes hard. So I think, being decisive, but also, knowing what you're decisive about, really having the framework and the mindset, and, knowing, kind of the background before you make those decisions is important.
Can you give an example of a difficult leadership lesson you had to learn the hard way, perhaps, and what you learned from it?
In terms of a difficult leadership lesson, I would say that, I don't know if it's a difficult leadership lesson, but one of the things that I learned when I came to Elliot was I watched, I think I was day 5, and I watched a dialogue between a group, I won't say which group, and our senior leadership, my boss and the president and COO. And I think it was just exactly that. It was, they were confident in what they needed to do, and they had the ability to say no. This is where we need to go. And it was contrary to everything everyone believed in that room, but they gave the basis, and they gave their perspective, and they were able to frame it in a way that folks didn't necessarily agree with it, but they understood.
Okay.
So I think, for me, I don't know if it was difficult for me, but the room was difficult, but it was, a frame where they really had to make some difficult decisions. Mm-hmm. And in doing that, they did, and they were confident about what they were doing, and they stuck to it, and they're moving it forward. And, as part of the leadership team, I'm carrying that out.
You talked about a mentor you had back a number of years back that you learned a lot of your leadership from. Have you had other mentors? Do you have mentors now? Do people you reach out to regularly now?
So I would say Monty Brown has always been, he's probably taught me the most in terms of, learning and leadership and that kind of thing. And I will say that my kind of thoughts aren't shared universally. I think he had a certain leadership style a lot of people liked and a lot of people didn't like. I would say over time I've surrounded myself with some strong leaders, and I don't hesitate to, reach out for them from time to time. There's Kate Walsh, she was at the Brigham when I first started reaching out to her. I met with her. She was at a women's leadership luncheon, and I reached out to her after, and she was kind enough and gracious enough to meet with me. And, I think that's what we do, is we give back, and that's what she was doing. Over time, I think during my move from children's to the Joslin, and even Joslin when I was starting to think about, what would be my next career move, I reached out to her. I also reach out to her when I see something in the newspaper, or, she does something really fantastic. I follow her career and try to, support her. She's, I would say in a more senior position than me, but, to do that. I think another person is Sandy Fenwick at Children. She's president and CEO there. I've reached out to her on occasion to say, what do you think about this? And, and she's, again, always been gracious, always willing to meet with me or, give me some career advice or guidance. So I would say I don't have one per se, but I have, I guess, a network. Yeah, folks that I reach out to. I also am a member of the Boston Club. It's a women's executive group, and I did a it's a peer mentoring program, which is really great. It gave me the opportunity to kind of think about what did I want to do, and, how did I want to progress in my career, and where did I want to be, and, just bouncing something off of someone who, wasn't even in the field. She was in development, and it was just good to kind of talk with her about different things. So I'd say, again, it's that networking, and it's the ability to, it's a two-way street too, that if something happens, I let Sandy know. I didn't call her when I was coming here, but I let her know. I just said, hey, I'm going to Elliot. And she reached out to me and said, we were working with them and, we had relationships with them. And so, it's that networking, and it kind of also leads to business relationships too.
Sure. Mm-hmm. So you mentioned you're a part of the Boston Club, so some peer mentorship. Do you have people that reach up to you? So young people coming up that reach up to you and look to you as a mentor?
Yeah, I feel kind of crazy saying like to me as a mentor. I feel like it's so important to give back, and anything I can share about things that I've learned with others. I did Suffolk University had a mentoring program most recently that I've done, and I've always committed to staying in touch with those that I've mentored. Usually they're programs, for a defined time period. But I had 2 students through that. I've done the mentoring program at UNH. They had a program through UNH broadly. Anytime anyone reaches out to me from, in particular, the HMP program at UNH, it's something I always committed to and dedicated to. I'd say a lot of the students that have come through and been my students through the internship program will often reach out and say, there's this or there's that. I had lunch with someone on last Friday from UNH who was my student. So I think it's important to just keep in touch, and anytime someone's kind of making a transition or thinking about something or thinking through something, or someone I had lunch with on Friday said, I'm trying to think about how to get a promotion at my job or those types of things, and just talking through that with them I think helps them. I hope helps them, but I think it's just great for me to stay connected, and I find a real joy to helping them.
You participated in a few women's leadership groups. So I wanted to ask you, as you know, the majority of the students in the program that I teach in HMP are women. So as a woman leader, what advice would you offer them as they're entering the workforce and entering the profession?
I would say, I think it's hard, but you have to be committed, and you have to know what you want. I think, as a woman, it's challenging oftentimes. If someone's going to start a family, it's oftentimes, the mom who stays home. And I think those are some career choices, if you really want to proceed and progress in your career, that you can't use as an excuse. I think that you have to find that balance, and it's hard. It's not easy. I wish I was home. I have a child who I mentioned last night. I was at her swim meet, finals, and I think that's really important. But to be able to find that balance between family, I'm very lucky. I have a supportive family, but it takes, I'm oftentimes calling my friends, my husband, because if I have a late meeting, I don't want to say, oh, I can't because I have to go home. So it's about finding that balance and never using children or your family life as a excuse. I think it's about, if you have a job, you need to be committed to it. And I think that's, something that's really important for young ladies or women in a career. Obviously, there's a work-life balance, and I think, we need to acknowledge that. But I'll say I probably put that to the side in my career, and I probably work too much. Is it my advice I'd give? No, but I'm pretty glad I did it, because it's, kind of helped me get to where I am. And I feel, I've had a very fulfilling career. I waited a little bit later in life to have my child because I thought my career was important. I don't know that I advise everyone, but I think, just being committed to your job and recognizing there is some separation and trying to, just be, when you're at your work, just be completely dedicated and, doing everything that you need to do to, help your organization or your department.
As we talked about, you've sponsored a number of interns from HMP as well as other organizations. What are you looking for when you select an intern, and what does a successful intern do while they're on the job with you?
That's a great question. So I hope everyone listens to this before they come interview. So I would say when I'm looking for an intern, I look for someone who's up for anything. I mentioned to you when I was back in Iowa, I would have washed the floors. I really would have, because it would have given me a perspective. I would have learned something. And I think coming in with that approach, that, I'm just here to learn, I'll do, if it means I have to file for a day, I'll file as long as you give me a good experience, on another time. For me, I will absolutely, again, I mentioned my leadership style is to give folks the information they need and to really help them learn about what they're doing. I will absolutely do that for an intern, but they have to give back to me. So I look for someone who's really, engaged and, wants to just, be a good, be part of a good organization, learn a lot, but also is willing to give back. So that's what I look for.
Okay. And what does a successful internship look like, you think?
To me, it's someone who ultimately I offer a job to after. So
that's pretty good success.
Yeah. So usually I try to find someone who, wants to come and learn. And in the back of my mind, I'm trying to set them up for something, I might not know what it is exactly when they come in, but inevitably through attrition, this is what we see in organizations, big organizations, there's always something that opens up. So in my mind, they come in the summer of their junior year, and I can help them acclimate and orient to the organization. I can teach them a lot about, a lot of different areas and help them learn. Obviously, I want to help them learn. And then throughout the next year when they go back, maybe they come back on vacations and I have projects for them to do. I often, put things aside so they can work on them. And then, at the end of their school year, they, come in and they have a job. And they're already trained, and it's great for me and it's great for them. So, they graduate, exactly.
All right. So last question. What advice do you have for someone thinking about going into healthcare administration today? What education should they be pursuing? What kind of jobs should they be looking for as they head out into the workforce?
Well, I can't say enough about, my alma mater and, program. I think the Department for Health Management and Policy and the program, HMP, is really just sets you up so much for, getting into the field. You do need experience, and I think the internship really gives you that flavor. For someone getting into the field, I think years ago, we all used to come out of the program and think we were going to be the next president and CEO. And I probably thought that when I was 15, going to meet with the president of Anna Jake's Hospital. But I think realistically, it takes time. It takes time to learn. This is such a complex, dynamic environment with healthcare. And there's so many changes and so much that's happening so fast. And I think getting into, the field in an entry-level position is absolutely, a great place to start. And it's not a bad thing. And I think the other thing is as folks get into the field, to find someone, a mentor, to network, to have those folks that have been there and done that, who can help them as they grow in their career. The other thing is I think, volunteering. So if you enter an organization in one role, doesn't mean you can't take something else on. If they need a volunteer to go do, I'll make it up, end-to-end testing for ICD-10, go do it. Think about how much you learn in terms of IT and being with those groups. And so there's so many opportunities for folks to volunteer and, do things above and beyond what their kind of day-to-day transactional job might be. So I think really to take advantage of those, find a leader who wants to, help you, interview your manager. If you're going into the field, know that this is someone who wants to help you. I think, as a leader or, manager, director, I often ask for a couple years. I'll give you a great experience. I'll teach you a ton. But, give me a couple years. And then I know you're going to move on and I'll help you. So I think that's what I look for. And hopefully, I think that's what, folks should be looking for as they graduate.
All right. Well, that's great advice. Thank you so much for your time today.
Thank you very much. It was my pleasure.
You've been listening to the Health Leader Forge, a joint production of the College of Health and Human Services at the University of New Hampshire and the Northern New England Association of Healthcare Executives. Please go to our website, healthleaderforge.org, for more information or to leave comments about today's podcast. Look for Health Leader Forge podcasts on iTunes, Stitcher, SoundCloud, and other podcast distribution sites. Thanks for being a part of the Health Leader Forge community, and we'll talk with you again in about 2 weeks.